You and I discussed this a little earlier. If it's essential services, does that mean that the workers, the employees of the dispensaries, caregivers who are considered essential, are we going to be considered essential workers when it comes to the vaccination schedule or
Well,
not?
I heard that they're going to be vaccinating grocery store workers and
That's
people like
right.
that they've asked to stay open. So I don't understand why there would be a differentiation between that level of essentialness and our level of essentialness.
That's what
Yeah.
I'm asking. I'm wondering.
I would agree. I know right now it's frontline workers is the phase 1A is frontline
Right.
workers and residents of long-term care facilities. But yeah, once it just
And healthcare workers.
the essential.
Yeah, I think 1B or C says essential workers, which is, teachers and people working in grocery stores and people working in dispensaries, people working in the greenhouses. Come on,
You
Rob,
don't at our stores.
You don't want to be first in line for the vaccine, okay?
I want to be first in line, so you're gonna have to fight me for it, Gus. Come on.
Gus says it's like the first year of a new car. You want to let it go through and let it shake out all of the rust.
He doesn't.
And the people who have pre-existing conditions, I think healthcare providers, the ones who are dealing with patients one-on-one, who have great risk of spreading the disease. So those are the ones you want to vaccinate first, and the elderly people. But the dispensary workers, so right now they're working on a drive-through. I think that's what I've seen in Ann Arbor.
A lot of lobbies are open, but curbside is what's.
Curbside. So I think,
hey Gus, would you since because you are from the College of Pharmacy, University of Michigan. A lot of people are concerned about the vaccine. A lot of people are concerned about how fast it was developed and many other considerations. Can you just talk about what you know from your expert position?
Yeah, so it is a very serious concern. The approval of the EUA, which is Emergency Use Authorization, by the way, that doesn't mean that it's for emergency use. It just means that it was approved really quickly as an emergency measure. The whole clinical trial was rushed through a 3-week period. Typically, vaccines are approved after a 2-year testing period, and then they go on into a gradual scale up to the whole of humanity over a 10-year period. So we're going from 3 weeks to the whole of humanity, bam, and that's something that's never seen. So another thing that's never been seen before is the fact that we're vaccinating in the middle of an epidemic or a pandemic. And that means that people are going to come to the hospital now to get vaccinated at a time where hospitals are going to be full of people who are sick. And that's something that's never been done before. And I don't know how that's going to play out. But certainly a 3-week testing period for a vaccine is not long enough to see all the long-term side effects that you'd expect to see whenever it is that you put some new drug out there that people begin to inject. So I would be a little bit careful. Now, the FDA is now setting up an adverse reporting system precisely to let physicians feed input, into the database that they're putting together in terms of adverse drug reactions as they're occurring in the population, which is all very good. And I would just wait for that database to be filled up a little bit before healthy people, and especially young people. So if you're healthy, you're young, your risk of hospitalization is very, very low. If you're older, elderly, then you have, the other conditions that predispose you to hospitalization, the risk goes way higher. So I would take a more measured approach in terms of, who should be vaccinated first. And I would actually advocate for gathering data as we're vaccinating people. So just be a little bit cautious. And
realize this is the plot line for about 50% of the zombie apocalypse novels, right?
Yeah.
Everybody gets inoculated with something based on an emergency measure, and then.
So what you're saying is that everybody should get the shot, and everybody's going to be okay.
Everybody but me.
Sorry, you all can watch how it affects me, because I'm going to be the first. The minute I can get it, I'm going to be up in there and getting it, man. I've been in the house for 10 months. Come on.
But it's valid. I'm sort of joking, but it's a valid concern, because one of the things that fuels people's distrust in vaccines is some of the popular culture things that we've seen about this, and they've been told that oftentimes injections lead to infections based on fiction that they've read, seen, or been fed through the media devices that we utilize. And then, of course, we've had the internet, which has amplified some of the concerns people have about vaccines and their relation to autism, things of that nature. So people are naturally concerned. And then take on top of it the liar in chief who pushed this whole thing through, and who's the one primarily saying, let's get this done. People that are hesitant because it's a Trump product as well.
This is being developed all over the world too. We're not in a little bubble here in the
that
US.
doesn't mean anything.
There's vaccines everywhere in the world, So.
No, that doesn't mean anything. It doesn't mean anything. I mean, it's history has taught us that we need to be careful about any time there's a new drug. And by the way, this is not a vaccine yet. This is actually an experimental approach towards getting a vaccine. It hasn't been actually demonstrated that it confers long-term immunity. It's only been shown to confer immunity over the 3-week period through which it was tested, okay? So beyond those 3 weeks, you don't know if you're gonna be immune. Okay?
Right, so Gus, do you know what the how common it is if something like this works over a 3-week period?
No, we don't know that.
Is that any kind of a significant sign?
This is a completely new vaccine technology. I mean, I don't even want to call it a vaccine. This is a completely new technology with a synthetic, it's not even an antigen, it's a synthetic.
You're talking about the messenger RNA technology?
Yes, messenger RNA. This is all new stuff, okay? It's a synthetic construct that they're putting into the body, and they're hoping or they're thinking that the way it acts is by generating the antigen, which is a protein or peptide antigen, which is ultimately what the immune system is supposed to be recognizing. We don't know whether this is going to last long enough beyond those 3 weeks. We don't know if the response of the body when it gets the booster after those 3 weeks is going to be, like quite catastrophic. I mean,
to be clear, Gus, one is synthetic. The Pfizer one is synthetic, and then the Moderna one is non-synthetic. Is that correct?
No, the Moderna one is also, I believe, I don't know the details about the Moderna one, but it's also synthetic. It's just not as synthetic as Pfizer's, but I just,
there's also AstraZeneca has one too.
So,
what does that one?
Yeah, I can't remember which way it goes, but I believe Pfizer bought the one from Moderna licensed Pfizer's version. So it was just an untested patent on this vaccine.
Look, the RNA technology is all new technology, and we just don't know beyond those 3 weeks what's going to happen, period. I mean, we just don't know, okay? So your guess that you're going to be protected after 3 weeks is your guess. I mean, do you think it's going to be a vaccine that's going to protect you after 3 weeks? You're guessing that. What's going to happen after 3 weeks? Could it get like a worse inflammatory response? We don't know. I mean, we just don't know. You have to go by the science. I'm a scientist. I'm a pharmaceutical scientist. I'm in the Department of Pharmaceutical Sciences, so I have to stand for, what I know. And what I know is that the science just can't go beyond those 3 weeks that we're used to gather the data.
Professor, so, I read a Facebook post that you made that said you'd read over the Pfizer data and you were concerned that there wasn't any evidence that some minority groups might be equally protected. Would that be correct?
So yeah, that's that. Thank you, Rick. So when the vaccine was being discussed, I was at the Zoom meeting, which was public, and the reviewers were discussing the vaccine. That this was one of the points that was raised by the reviewers, that there was no data that the minority groups that were presumably at greatest risk of being hospitalized and dying from the disease were being protected by the vaccine. These are the elderly African Americans, the elderly Hispanics, and the elderly Native Americans. And there was just not enough data in that group of people based on who had got sick during those 3 week periods to figure out whether the vaccine was actually working in those groups or not. And when the EUA was voted on by the panel, by the review panel, 3 reviewers voted against the EUA, so against it moving forward, okay? 3 reviewers. It was not unanimous, okay? And for a brand new technology, to have 3 reviewers voting against it, in my opinion, is very concerning, especially because you're gonna give this vaccine to the whole world as it's being done right now. Okay, so if it was going to be scaled up to the point where we're going to be finding out what's going on before we give it to everybody, okay, then I would say, well, I'd be a lot more, cautiously optimistic, okay? But right now, with 3 reviewers voting against it, voting no for its approval, I'm like very cautious. I just want to see what's going to happen before I even consider injecting it. And I'm personally, I think in over the next 2 years, I mean, I'm going to wait for 2 years, which was the original clinical trials goal, was to figure out what the outcomes would be after 2 years. So I'm planning on waiting 2 years. And by the end of those 2 years, I think I'm just going to get COVID just because it's going to be everywhere. Okay, so I won't even have to worry about the vaccine at that point. That's my own, bias. That's my bias.
What if the university says we require a vaccine certification in order for you to teach in person? Would that change your mind as to receiving a vaccine ahead of time?
I don't know if they can do it. I mean, I don't know if they can do it. I would have to.
Yeah, they can. Michigan's
Oh yeah, no. There's definitely discussion of like venues of like.
Well, then I'm gonna say you're gonna have to approve my hemp research program, which is legal.
Gus says, "I'll just work in this barn, okay? I don't have to integrate with everybody else. I'll do my thing."
I'm gonna need a lot of CBD to deal with that.
Yeah. Okay. All right. Well,
let me just. I got a quick question, if I could. So this vaccine, is it in any way effective against the new strain that's been found in Europe?
I don't know. I haven't. Some people I've heard that maybe. But
yeah.
I don't know.
No, I mean, if anything, just to further your point, there's that new strain in, like I want to say parts of London and the surrounding area that's like 70% more infectious and like a variation on the original strain.
Yeah.
So
it was discovered there, but it's here by now.
Yeah, it's in Canada too, they were saying. And
there's a whole second thing that's even worse.
Yeah, we don't know that. And the thing is that, when in the trial there were 20,000 patients that were recruited for vaccine, 20,000 for placebo. So there were 40,000 patients total. This is the Pfizer vaccine. And then out of those 40,000 patients, only a small percentage actually got sick. And once enough people got sick, that would allow the investigators to tell whether or not it was being more effective in the vaccine group versus the placebo group. Then they went ahead and they asked for this EUA expedited approval. But they just got enough people sick out of the 20,000 to know that there was enough of a difference in terms of, say, COVID hospitalizations, which is ultimately the important outcome, because whether or not you have antibodies, that doesn't mean that you're truly protected or not. What really makes it is whether you're getting sick, whether those antibodies are keeping you from getting sick. So once they saw that difference, they went for the approval. Now, the interesting thing is that when they look at hospitalizations, they only compared the COVID-related hospitalizations, but they actually don't report the overall hospitalizations, okay? And that's a real concern of mine, because if you look at, say, something like appendicitis, there were 8 cases of appendicitis in the vaccine group versus 4 cases in the placebo. And presumably, if you get appendicitis, you're going to be hospitalized, okay? So at that point, your hospitalization numbers, if you look at total hospitalization, they don't start looking as good. So whereas if it's COVID hospitalization, it's 9 in the placebo group versus 1 in the vaccine group. But then if you start incorporating the appendicitis and you think, oh, appendicitis involves hospitalization, then that difference, that benefit in terms of hospitalization no longer looks that good. And I don't know what else in that trial, what other side effect or condition require hospitalization. So is it actually going to reduce hospitalization? I am not that sure, but what I do know is that when you're going to vaccinate 8 billion human beings with a vaccine that's potentially, inducing an anaphylactic shock, you're going to be asking the vaccine to come into a doctor's office that have resuscitation equipment, and generally that's a hospital. Okay, so just by the fact that you're vaccinating in the middle of a pandemic, you're going to be bringing people into a hospital that you probably wouldn't be bringing. So in terms of what the hospitalization difference, whether you're vaccinated and not vaccinating, actually means, I'm not sure what it means. I'm just not sure.
All right, so Gus, though, would you handle this any different under the circumstances? Just given the totality of the emergency, you know.
I would take a measured approach. Like I said, you know, the people at risk, you know, you first vaccinate the people at greatest risk.
But you would still get the vaccine out fast and all this. You'd still get the vaccine out with 3 weeks of study. And then
yes. So this is
better, maybe. Okay.
You know, like I'm not going to go back in the past, because that's, you know, there's no point. I mean, there's no point to that, right? So we just move ahead because it's a done business. Okay, it's done. So what we need to do right now is we need to vaccinate the people at greatest risk. Okay, and then we need to start looking at total hospitalizations. I mean, the ultimate outcomes, it's not about whether or not you have antibodies. It's not about whether or not you're getting sick of COVID or not. It's just whether or not this vaccine has an ultimate benefit. Okay, and that ultimate benefit is measured in terms of whether people are going to the hospital more or to the hospital less. Okay, and that's what you want to know. And it doesn't matter whether they're going to the hospital because of COVID, because of appendicitis, because of a rash that they suddenly develop and they can't explain how they got it, or because their hay fever is so bad that they just have to go to the emergency room. It doesn't matter. So you just have to look at hospitalizations in the context of what this vaccine is doing. And I would say, first, let's vaccinate the people who really, really need it. And these are the people who are very sick in hospitals from some other, pre-existing condition like diabetes, obesity, hypertension, heart conditions, cancer, or we also vaccinate the healthcare providers that are in immediate contact with the patients. And you don't want those people spreading the virus from one patient to themselves and then to a different patient. And that's what generally happens. Okay, so when you have a hospital, you have doctors and nurses interacting with many different patients at once, and they breathe in the virus from one patient and they breathe it out into another patient. And you don't want that. So those doctors need to be protected. Okay, other than that, you just keep track of the numbers, keep track of hospitalization, adverse events, COVID-related conditions, and then you make decisions as you move forward. So just don't rush it. Get the information, you know. But hey, you know, like we've been winging it in this pandemic from the beginning, right? From day zero, we've been winging it. So
Rick
it seems like that comes with the program. Go ahead, Berg. I'm sorry.
Now, Rick stated earlier about, you know, having to take the vaccine to go to college and stuff. Well, there's going to be employers that are going to fucking want people to, you know, take the vaccine.
All types of things, events, concerts. Just talking that type of thing.
You know,
and they're legally covered to enforce that on their employees to remain employed at said business.
Yeah, so I think this is where people like myself comes in, you know, where we have different ways of looking at things. I mean, obviously I'm very much pro cannabis and, you know, pro sacred plant medicine, bringing them back into our pharmacopoeia. I also have a very different way of looking at this vaccine and everything that we're doing in regulation. And this is where people like me come in. So if I'm at the university and I'm suddenly being forced to be vaccinated in order to teach, you know, they're going to hear about me, you know, I'm staying quiet right now, right? I'm just, you know, I'm keeping quiet about the vaccine and just say, I'll play along with it. I think they're doing it fine. But if they suddenly start forcing people without having enough data to support this, this notion that actually making people take the vaccine is actually going to lead to better healthcare outcomes overall, not just COVID related, but overall, I'm going to start becoming increasingly vocal. And, that's just my role as a faculty member. You know, like I think about things, and then to the extent that I'm not working in COVID related research right now, you know, I stay quiet, but if they suddenly start forcing COVID vaccines on me, then I'm going to be forced into the conversation. That's not a position I want to be in, honestly, because I would much rather advocate for plants and fungi. So that's my real. I think that's what's going to ultimately change healthcare. Period. So that's going to make the whole difference. I'm not going to waste time with the vaccine. But if they start bringing the vaccine as something that you have to do for employment, I mean, I'm not going to just stay quiet. So I'm going to become vocal.
It'll be really interesting to see how these things unfold. This is very weird stuff going on.